evidenced by the research. So sharing that will be really important.
So when you mean didn't work, meaning they had like PRP injections that didn't
Exactly.
work, or stem
Stem
cell
cells.
injections, they spent a lot of money, they're disappointed.
Yeah.
Yeah, I mean, shoot, we talk about a whole bunch of different reasons why that could be the case. But I mean, if I had to summarize it really into two main reasons that are described the most in the literature, I mean, I think we could agree that the reason why the outcomes for regenerative medicine are not quite as good as what we think they should be is really two things. Number one is the consistency of what is being injected. So it's really, are all these physicians doing the same orthobiologic injections, right? Like, are they preparing them the same way? Are they counting the number of platelets? What's the number of stem cells? Where did they get the stem cells from? What was the state of the stem cells or the platelets? In other words, what was the health of them? Like when they took the sample out, what did the rest of the patient's system look like? Right? Were they compromised? Were they recently sick? I mean, all of these things make a difference. And so when you don't have that consistency as you're performing these procedures, and then you start to put all those patients together in order to draw some conclusions, it's difficult.
Hmm.
It's really difficult. Now, I think from what we read in the literature that they're trying really hard to standardize it and to figure it out. Um, one of the guys, one of my big heroes down in Miami, Dr. Carley, he actually has created a machine where after he takes the sample from the patient, he actually put it in the machine and he can quantify all that stuff. I mean, he can actually see the cells. He can look at the health of the cells. He understands like what he needs to add to those cells in order to, to complete a better recipe so that the chance of success is going to be greater. In other words, not only does he have the machine, but he's built out the AI in order to be able to predict, what is the chance of success in all these different patients, depending on what their problem is, right? The second thing that I think is even more important, particularly because you're talking to us, is almost every single research article on regenerative medicine really has concluded that a big component of this is what comes after, right? They all really agree that no one's having that conversation, but yet it seems that physical therapy or rehab, it needs to happen after the orthobiologics so that we can really do the right things in terms of loading, in terms of exercise, in terms of all these different technologies to keep the stem cells alive, keep them proliferating, get them to differentiate into the right cell types so that we can really orchestrate that repair in a way that is efficient and makes sense. And then we can also call other stem cells to the area or promote better migration, right? So that over time, those stem cells continue to do all the right things so that at 1 month, 3 months, 6 months, right, with the right care, that we can really optimize those outcomes. And at this point, I think there's a lot of physicians that have big opinions about what that rehab should be, right? But I certainly would say that they don't all agree, right? And it's a lot of just opinions. So what we've really tried to do with this course was, look over the last 10 to 15 years of research and look at all the different tools that we have, accessible to us and how they affect stem cells and platelets and different tissue types and different stages of healing. And then look at like, what should we be doing in all the different phases after these regenerative medicine procedures to truly optimize, the success or the outcomes, from these physicians. So, I think a broader way of saying that is I think Ben and I recognize that the way forward for rehab is we've got to figure out a way, number one, to get the patients better that everyone else fears. Like the patients that typically get cycled through the system, the ones that no one else can help, the one that's been to this physician, that physician, they've gone to the chiro, they've gone to two different physical therapists, and now they're kind of resigned to just living with their pain. Like we got to figure out a way to treat those patients more comprehensively to really give them their life back,
Mm.
right? I mean, the patients that are out there, they're a dime a dozen. I mean, if we could just open up the floodgates on those patients, right? And just give them a safe haven, give them hope again, that's everything, right? I mean, that's really going to help us to, broaden our scope of practice and who we're able to reach and,
That's
you know,
huge.
impact 100%. But I think there's many different examples of those patients, whether you're talking about headaches, whether you're talking about temporomandibular dysfunction, sexual health, pelvic floor, autoimmune, patients that have had concussions. But maybe the best example are patients that have had regenerative medicine.
Mm.
Like, I mean, those patients are not decreasing, they're increasing. I mean, there is no doubt about it. The way of the future for rehab is regenerative medicine, and certainly part of that regenerative medicine needs to include a look at the entire system, meaning functional medicine as well.
Mm.
And I think trying to just really set forth a new standard, a different paradigm, right, and kind of push PTs like how they can stand out from the rest of the crowd, from the other clinics, how they can really show an exceptional level of care, right? And bringing in all these patient types, like why not start with regenerative medicine so that as a profession for the first time, like we can actually set the standard, we can write the protocols, like we have an opportunity to actually teach the physicians something about the rehab, which is our specialty for a change, right? Earn a seat at the table so that we can actually have the team approach to patient care instead of all these individual silos, where we can really get together, exchange ideas, talk about the different things that we do, package it in the right way in order to truly be able to change lives.
Yeah. So, I mean, that's kind of tied into the medicine approach, right? The 3.0, which is, longevity and also health span over lifespan, right? So, most of the time when people have like PRP injection, like Jerry mentioned, they tend to have almost immediate bioremorse, right? The way after I took you guys' course, the way I looked at it is that you just save up a bunch of money, buy the Porsche 911, but you're driving out the lot without having car insurance, which is the proper protocol.
Yeah, but they don't know what they don't know.
Yeah.
Also, investing into all of the right things to ensure the success of the Cadillac that they just bought,
Yeah.
right? But I think most patients just aren't aware of that
Mhm.
because physicians really don't know what to say and they're not really pushing that right now. I mean, we're obviously trying to change that. But I think what Ben and I see the most and Ben in particular, I mean, he started the first regenerative medicine physical therapy program in the country working for Dr. Fortin. But what we see is that after these injections, the expectation from patients is not necessarily appropriate, right? Like they don't really understand like what is the timeline. They feel they start to feel good, right? And and because they don't understand like how all of the science works, right? As soon as they start feeling good, oh wow, my investment was great. Now they're back to doing the things that they love, right? And it's been 4, 8, 12 weeks since they've been able to do that. So now they're super motivated. And what we find is they do too much too fast. They drive this massive inflammatory response, which is the worst thing that you could do for regenerative medicine because now that you have this environment of inflammation, and it basically creates a situation where the platelets and the stem cells cannot continue to survive over time. So, I mean, you want to give yourself a reason to have buyer's remorse. I mean, you basically just negated
Yeah.
what it is that you just bought.
Yeah. So, can you guys break down in an ideal world after someone gets a PRP injection, how soon should they start rehab, and what
Yeah.
does that modality and rehab protocol look like?
Yeah, so that's an important question to ask. Not an easy
Mhm.
question to answer. And the reason for that is because it depends. So it really depends on what was the regenerative medicine procedure, right? Like the answer for PRP is going to be different than stem cells. And oh, by the way, where the stem cells came from is also going to determine the answer. Did they come mesenchymal stem cells from bone marrow? Was it a BMAC? Did they take it from fat? Right? Because that's two different things as well. So what we really have done as part of the orthobiological hacker program is, I mean, we have done the research to be able to answer that very question on every single regenerative medicine procedure and for every single major tissue type that you would want to treat, so that the mystery of that should be no more. I mean, it's a mystery until you come and at least listen to what we have to say. But the point is if we can standardize what we do according to the evidence, right? According to the largest studies over the last 10 to 15 years, the ones that have really set the standard in the medical community for regenerative medicine. And we can map that out, which is really what we've done with our iris method. Then I think every rehab professional is going to be able to answer those questions no problem.
So if we go case example that you gave with your sister-in-law with the Achilles tear, can you walk us through exactly the timeline and what she did and what
Yep.
you did to help her to get back to running the marathon in
Yeah.
3 weeks, right?
Yeah,
Yeah.
4 weeks. Yeah.
Okay.
So one of the things that we did, which was kind of critical to it, is first of all, we put her in a heel lift, right? Like activity instructions are really important. Like telling the patient, hey, you need to take some time off of this. You can't just expect that we do one treatment and you can go back to doing everything. Really trying not to sabotage, the healing process and
Yeah.
the integrity of it. And really what we did is, I caught it within 24 hours because I was teaching a class, had to fly home and, get back on a Monday. And first thing that we did is we did some just assessment. Like one, was it completely intact? Was it completely avulsed and like it was truly a surgical indication? But it was intact. She had pain with movement, she had pain with resistance, and there was clearly a bruise and kind of a gap where the muscle had started to pull away from the tendon, like right at the myotendinous junction on the gastrocnemius. And really what we did was we did some dry needling, above and below the issue in the healthy margins of the tissue. We did some light winding just to help express the fibroblasts and really start getting those two ends of that tissue to start communicating together, running electric through it. We did some simple blood flow restriction therapy. So we were at about a 40 to a 50% limb occlusion pressure. I worked her, and that was continuous. We worked her through some, simple isometric exercises and really some range of motion exercises with it, to be fair. We did some ARP wave, proximal to the injury as well as distal to the injury, really trying to promote some of the benefits of microcurrent and some other things. And then really did some class 4 laser for anti-inflammation. And this was all the same day. Like this was like day one. And I know that seems like a lot, but most of us, other than simple range of motion or maybe throw some tens in a hot pack on it, like what else are you going to do? It's really hot and inflamed, and don't be afraid to just dive right in. I told her, don't ice it. Like, don't try to do anything that seems counterproductive to pain. And then 4 days later or so, I started doing some more in terms of laser anti-inflammation, did some needling above and below it again, and really kind of did that over the course of 2 weeks or so. At about the 14-day mark, I started introducing some focused shockwave to it, because at that point, the integrity of the tissue has started to change. You've started to see some of the pain with movement has started to decrease quite a bit at that point. And then really at that 3 week mark, I took her out of the heel lift. I had her try to normalize gait as much as possible. Use the ARP wave to kind of do that with her. I had her put it on her calf, put it on her hip, and just try to do some normal, just heel toe walking, just forwards, backwards, like do some lateral stepping, really to kind of get out of any sort of fear avoidance, situation. And then from there, by like day, 28 or so, I was like, like, why don't you try to go out and do like a light jog, just see how it goes. Because when I first got her, the first day, she had come from the walking clinic on a Sunday and she was in a walking boot. That's most of our patients,
Yeah.
right? And it was, well, you need surgery in 2 weeks.
Yeah.
And yeah, so she ended up going back to running, and it was a good experience. But just diving right in and understanding the science and the timeline, that's what this is all about.
That was after PRP.
No, this was just on its own, and then she ended up doing the
Okay.
PRP later on it. So
Okay.
So I asked that question because like what he just described, I mean that would be too much after a PRP. I mean, the timeline would be different.
Yeah.
Is the point?
So after the PRP, you would just let the stem cell do its thing, but then you can still treat above and below to facilitate more cell proliferation and then more stem cell recruitment, correct?
Yeah. I mean, look, I maybe I'll start. I'll let Ben finish on this one, but I mean, at first, the patients there's going to be an inflammatory response, but that inflammatory response, when it comes to regenerative medicine, is not a bad thing. right? I mean, patients almost need a little bit of that information because you could kind of think of that as the instructions to tell the stem cells or what was injected, like what needs to happen, what's going on, what are the marching orders, right? I mean, without that information, there's a lot of confusion, it seems, right? But I mean, eventually you get to the point though where, okay, everybody understands what they're supposed to do, right? And now we don't want to have lingering inflammation because if that environment of inflammation continues, well, now we make an environment which is not really appropriate for those cells to exist with time, right? So now's the time where we would start to, in a rehab way, like we got to get the inflammation under control, like we really have to, create something where those cells are happy and they're doing the things they need to do and they're multiplying and they're bringing their friends over and that sort of a thing, right? I mean that's the initial stuff, right? Which is then we would think through. Okay, so of all the things that we do, whether it's movement or we're talking manual therapy or all these different technologies, like what could we do to achieve that? Right? So maybe something we could do early on is consider some photobiomodulation, right? Some of this laser stuff because we know that we really can do that in order to quickly take some of that inflammation away, based on the effect of the laser with changing metabolism in the mitochondria and all of that. Um, that might be the quickest way. And then as time goes on, right, then the idea is we work into some more of the complicated things. So, but when we start that, it's going to be different. I mean, Ben always says like after a PRP injection, we're talking about, you got to give the patient some days, let things calm down that initial inflammation, and we're talking maybe at 7 days out, right, give or take, right? But when it comes to stem cells, maybe a little bit more, and certainly it's going to be a little bit more if we're starting to talk about like adipose-derived stem cells. And there's a lot of different reasons for that. But those are the conversations that we want to be able to have, right? Like, there's no reason why we can't make it our business as a profession to understand what's going on with the physiology, understand the tools that we have available to us so that we can actually lead from the front and explain to these physicians, what we can do in order to help their patients to achieve the best outcomes, like how we can really play a part in regenerative medicine if regenerative medicine is going to be the way of rehab. If we don't do that, and we start waiting, I don't know, a couple more years, I promise you, we're going to start seeing a protocol from, this institute. We're going to get a protocol from Stedman. We're going to get another one from Andrews. And I guarantee you, they're probably not going to agree. And then we're going to be managing all these different protocols, right? When, when, why don't we dictate what it should be for once? Right? Like, let's make it our business to understand the research and what's going on and the physiology and really be able to